Good morning, everyone. My name is Adam Rosatelli, Director of Finance for the OAA. It's my pleasure to welcome you to the October 24th offering of the Virginia Opioid Abatement Authority's Abatement Academy, which is a series of free presentations designed to help communities identify strategies for addressing the opioid crisis. This series features speakers who voluntarily contribute their time to share examples of best practices for opioid abatement and remediation strategies, as well as technical assistance toward applying for OAA grants. Today, we are very excited to be joined by members of the Virginia Commonwealth University Health System faculty and staff to discuss the online toolkit that provides evidence-based best practices for opioid abatement programs at the community level. So this program, which is an OAA-funded endeavor, it's a collaboration between VCU and the Virginia Society of Addiction Medicine, or VASAM, to develop a free web-based resource that cities and counties and community partners may use to assist in reviewing best practices and examples of various opioid abatement efforts developed and implemented at the local level to help inform how those practices and resources may be emulated throughout the Commonwealth. So before we jump into this topic, there are just a couple of housekeeping items. So first, if you have any questions, please type them into the Q&A feature. And also this webinar is being recorded, as you probably heard just a moment ago. So both the recording and the presentation will be posted on the OAA website in just a few days. So with that, it is my pleasure to introduce our speakers for today. So first, Dr. Jacqueline Britz is a family physician in the Department of Family Medicine and Population Health at VCU. She provides care at the Hayes E. Willis Clinic at Southside Richmond. She is also a clinician researcher and serves as co-director of the Ambulatory Care Outcomes Research Network, or ACORN. She has a background in public health and is interested in research on opioid mortality, addiction, health equity, and the intersection of primary care and public health. Also, Dr. Marshall Brooks is an assistant professor in the Department of Family Medicine and Population Health at the VCU School of Medicine and leads the qualitative research efforts of the Ambulatory Care Outcomes Research Network, or ACORN. A cultural anthropologist by training, Dr. Brooks conducts research aimed at understanding and improving healthcare delivery and behavioral health and substance use treatment systems. And I know we are joined also by a couple of other staff members, Dr. Jerry Moeller, as well as Tyler Burton, who aren't presenting but available to answer questions if they come about. So with that, I'd like to hand it over to our first speaker, Dr. Britz.
Hi, everyone. Nice to meet you all. Let me know if at any point you can't hear me okay from the attendees. I'll go ahead and share my screen. All right. Can you all see that okay?
Yes.
Wonderful. So again, I'm Jackie Britz. I'm a family physician at VCU. Spend about half of my time providing clinical care and half of my time co-directing our practice-based research network, which is a primary care practice-based research network. I'm really interested in this particular topic, looking at how do we address opioid mortality in Virginia. And I'm excited today to talk to you more about work we're doing to build an opioid abatement authority toolkit. As Adam mentioned, this is a toolkit with evidence-based resources to help cities and counties apply for OAA funds and to help them use these funds when available. And so I'll give the first part of our talk and then I'll turn it over to Marshall. And so today I'm going to talk about the toolkit and the process we go through. I'm going to talk about some evidence-based tools and programs in Virginia. I'm going to review some of our community level data we have throughout Virginia, as well as community outreach and consultation, which is when I'll turn it over to Marshall. And then we're in the early stages of this project. We would love to get feedback from you all. Any ideas, gaps that are missing in the toolkit, success stories in Virginia that you think we should be flagging, please let us know. So our team, this is a collaborative community engaged project through VCU and Virginia Society of Addiction Medicine. This is funded by the Opioid Abatement Authority. We work in the Wright Center for Clinical and Translational Research and the Virginia ACORN Network, so across a variety of different sectors. The VCU Wright Center is a center for clinical and translational research, and so it aims to advance science and foster partnerships that accelerate translational research for the betterment of human health. And so, essentially, one of the core reasons we got involved in this toolkit is because of this particular aim here. using health outcomes data to develop tools and methods to document differences in health outcomes, and working to promote health equity. So this is a core aim of the Wright Center and the Opioid Authority work, and this particular toolkit will help us promote the health of Virginians. And then the Virginia Society of Addiction Medicine is essentially a medium for Virginia physicians and trainees that are really passionate about addiction medicine to get involved. And so they're interested in promoting resources and helping communities to address opioid mortality. We have a lot of people working on this project, so we're particularly thankful for the OAA, including Tony McDowell. Our VCU team is made up of a variety of folks. We've got family physicians, psychiatrists, we have anthropologists, we have individuals who are managing this project and experts in community engagement. We have folks that are experts in biostatistics and analytics. So really a broad variety of people that are trying to think through this problem. And so just starting with the overview of the toolkit. So as you all know, the Opioid Authority funds present an amazing opportunity to address opioid mortality in Virginia. There has been a national push to make sure that the use of these funds is evidence-based. And we noticed that the communities are on a wide spectrum of needs. Some communities really need help identifying priority or areas for applying for funds. Some know what they want to do, but have trouble with how to implement these programs. And some programs have very concrete ideas, but really need data to support their applications. And so our goal is to help across that spectrum. This toolkit is specifically for cities and counties to apply for and use opioid abatement funds. It aims to have community-specific data. So right now it has a menu of evidence-based options and very specific examples of community programs in Virginia. Over time, we plan to put additional community-specific data to help communities understand, are there high levels of postpartum mortality? Are there high levels of neonatal abstinence syndrome? You know, how can I target specific priority areas and have that inform our funding? We hope to also use this to facilitate partnerships. So here are the chief components of the toolkits and process. So we aim to build a toolkit based on the 9 opioid settlement use strategic areas. These go over postpartum care, neonatal outcomes, incarcerated populations, looking at warm handoffs and peer recovery services, prevention. Well, I'll show you in just a few minutes. We aim to evaluate gaps in what is needed. We want to research and evaluate promising interventions and incorporate them within the toolkit. A big piece of what we're doing is community outreach. We have a lot of large data sets, but we need that community context. And then also we're providing consultation to cities and counties to make use of this data and help our data inform what they're doing. And so this is a big picture overview of the process we've been going through. We started with a needs assessment. We're in the process right now of doing a toolkit development and iterative community engagement. We're using a broad variety of data sources. So we're using something called our bright spot data, which is, we've created a model to identify communities in Virginia that have lower opioid mortality than we would predict based on their risk factors. And these communities have a lot of things that we can learn from and potentially scale up to other areas. So we're using that data. We're using community level protective factors. We're doing a survey of individuals across the state. And today we'd love to share that survey with you in case any of you would like to take that. We plan on meeting with communities and cities and counties. We've gone to opioid workshops. And the goal is ultimately to learn from communities to help inform this community toolkit. We want to know what's going on currently, where are there gaps, what's working well, what's not working well, how can we learn from what is going well to apply to communities that have gaps in resources. And so this is what you'll see if you go to the OAA toolkit website. And so I'm going to actually navigate to this to give you all just a brief view of the toolkit. Can you all still see the website right here? Okay, great. So when you go to the toolkit, you do have to log in, but it's a free login. It takes about 30 seconds. And as you go down, you see the 9 core strategic areas, and you can click on any of these different topics. So I'll bring you through 2 of them. So this is the broaden access to naloxone. It gives a brief high-level overview. And then it goes through this menu of options. These are evidence-based strategies that have been shown to work in other areas. These are the general principles, but then these are very specific examples of where it's been put into place. So one example being community-based naloxone distribution, we know is an evidence-based practice. Here you can see that the Eastern Shore Community Services Board has implemented 4 harm reduction vending machines. These vending machines distribute a wide variety of supplies. And if you click on here, you can see what supplies are actually in these vending machines. And over time, right now, this is more, surface level. Over time, we want to interview this community to figure out, how did they do this? What were the barriers? What made this work? And how can this be implemented in another community? And so those are one example, but you can look down and look at Revive trainings, pharmacy distribution. And then at the bottom, we've got a few different categories. So you can look at OAA funded examples specifically. So what has the OAA funded that's in place right now? What have other people done outside of the OAA? There's a lot of amazing programs happening in Virginia. And then what are some other training guides and resources that are evidence-based? And you can scroll through, there's a lot of them here. What we'd love from you all is, if you're aware of successful programs throughout the state that should be featured, please reach out to us. And if you're aware of additional resources and guides, we have some gaps, so we would love to fill them. And I'll show one other example here. So you can go to warm handoffs. This is looking at, transitions of care and peer recovery services. It gives an overview. You can see very specific strategies that have been found to be effective elsewhere. And then here, we've got a lot of examples in Virginia of, these are OAA specific programs. If you click on, this is a CSB in Louisa they hired a full-time clinician counselor. And if you click here, you can see the application that they submitted to the OAA. And this is all publicly available on the OAA website as well. So this is just a few examples, but there's and lots of different examples for OAA funded programs here. This is, again, kind of middle stages. We're still building it out, but you will also see community spotlights. These are communities that are really doing something innovative, thought-provoking that we think other communities can learn from. We have a handful here already. So examples include the Crillian ED Bridge program. And I'll go through a few of these in my slides, so I won't stay on this, but you can skim through. And then just a few other things to be aware of. If you look down, we've got dashboards and resources, and these are just compiling some state level data that is helpful for others. And so I'll go back to. And so that brings me to some evidence-based programs. So if you look on that website, there's already a lot of things in place that we're building out over time. Here are a few examples, looking at kinship navigator programs to how do we treat pregnant and postpartum women? How do we care for health, how do we promote health of kids? And so a few programs we look at in particular. So the Chesterfield Sheriff's HART program helps individuals who are incarcerated, providing a wide range of therapies for individuals with substance use. And a key aspect is helping find recovery housing. I mentioned the Crillian ED Bridge program. So this is a program that helps to help with those transitions of care. Individuals who come to the ER, help them into long-term recovery, getting prescriptions, peer guidance, access to treatment. And really the next piece is which programs have data for them. So a lot of programs are early on. We're still collecting data. The ED Bridge program showed that rates of follow-up for patients with OUD increased from 10% to 82%. And then we look at, the Chesterfield EMS mobile program. So this is a mobile integrated healthcare unit. In 2017, they incorporated peer recovery specialists. Some of them have spoken at some of the OAA workshops, but they provide home visits, naloxone, and providing connections within the community. A lot of these programs are successful due to some local contextual factors and partnerships, but there's a lot to be learned from to apply to other communities. And I won't go through all of this, but this is a summary of some of the key OAA funded programs that have been in place for over a year and already have some data. So this is mainly to show you the broad scope of programs that are already being funded. So in Abatement County, there's programs with the local CSB to expand harm reduction, prevention, education, and clinical services that have already shown to improve mental health care for 50 incarcerated individuals. We've got Buena Vista, that's more working on recovery housing, and that has diverted multiple individuals from incarceration and connected them with services. In Culpeper, they're working on harm reduction kits. They've distributed over 2,000 harm reduction kits already and have done a lot of trainings. And then, you look at Louisa, they've connected more than 130 individuals to mental health services through expanding their Region 10 programs. We've looked at some programs that are expanding their peer recovery services and counseling. And then Stafford, just to think through innovative ideas. A lot of programs have asked us, what's already happening on the ground that we might be able to learn from. Stafford County has worked to identify hotspots for opioid use so that they can quickly monitor overdose patterns in real time. And so that brings me to the community level data. And so one priority for our team is using the data we have in our research office to help inform communities. There's already a lot of data out there, so we don't want to duplicate what's already available. some things that we have that can be helpful are census data, claims data. So claims allows us to not only look at fatal overdoses and ER visits, but what about patients who have a diagnosis of opioid disorder, who's on medicines, who's not? Are there specific priority areas in terms of pregnant or postpartum women, kids? And then we also, of course, have the Virginia Department of Health data. This is data we're working on analyzing. It's not yet on our website, but I want to show this today to get ideas of what's most helpful to include on our website in the future. So we have some pregnancy outcomes. So this is a map of diagnosis of opiate use disorder in Virginia. And you can see generally Southwest Virginia counties have higher diagnosis of opiate use disorder. And this can actually be a good marker of individuals who are actually linked with care with a physician. And similarly, we actually see for pregnant women with a diagnosis of opioid use disorder, this is the rate of individuals on medicines for opioid use disorder. So this is definitely, we consider a positive outcome. Southwest Virginia is doing really well with linking pregnant women with care. And there may be, things that we can learn from in those areas, and there may be barriers to doing so in other communities. So this, I'm going to walk you through this because I think this is worthwhile looking at. So this is looking on the top graph. This is the rate of emergency room visits for opioid overdose, specifically for postpartum women. Each circle on here represents a county in Virginia. And so as two examples, the blue arrow represents a county in Virginia with very high emergency room visits for overdose for postpartum women. The red arrow represents a county with virtually 0 ER visits. On the bottom, you see the opposite. This is the rate of medicines for opioid use disorder among pregnant women. And again, that's largely a positive factor for individuals who have opioid use disorder getting treatment. And the arrows line up. So the blue arrow there, this is a community that has very low rates of medicines for opioid use disorder on the bottom graph, but very high rates of ER visits. In contrast, the red arrow points to the same county in both locations there. It has very high rates of medicines for opioid use disorder and very low rates of ER visits. In other words, we're seeing a general trend that communities that can get people in earlier for diagnosing opioid use disorder, getting them on medicines, getting them into treatment for mental health, these individuals tend to have fewer rates of ER visits and mortality. And so we can look at some other outcomes. I won't go through all of them, but just to give you a broad overview, we can look at rate of counseling for individuals with opioid use disorder. We can look at rates of recovery housing as well. And we can also look at trends over time. So on the left, this is looking at 2016 to 2021. We're able to compare several different localities based on their rate of neonatal abstinence syndrome. And on the right, we're looking at rate of recovery housing. And a lot of communities have had a really significant improvement in recovery housing over time, even if they're still below where we want them to be. And then finally, our bright spot data. So I mentioned this earlier. This is a project to identify communities that have better than expected outcomes, so lower mortality than we would predict based on their local risk factors. There are some communities in Virginia that may have high mortality, but they also have a lot of risk factors, in terms of disability or poverty. And this tries to account for that and see what communities are actually doing much better than we would expect and take more of a strength-based approach. And so this is old data. We are reviewing and revising this right now, but just to show you an example, the blue spots here are bright spot communities. These are communities in Virginia that have lower mortality than we predict. The size of the dot is not the geographic area, but actually the magnitude of the bright spot. And so you can see in Eastern Shore, there's several bright spot communities that are doing much, much better than we would predict based on their local risk factors. We're also mapping here cold spots, for lack of a better term, but these are communities that have higher mortality than predicted. And when we compare the two, broad picture, we're seeing that communities doing better tend to have more primary care visits, more mental health diagnosis, more opioid use disorder diagnosis, going with this overall theme of these earlier access to, and more as a proxy for healthcare. Individuals who are getting that early access to mental health and opioid use disorder treatment are generally doing better with lower mortality. And then there's some, local examples that, there's so much going on in Virginia that is really working well. And along the Eastern Shore, they have the first overdose review team in Virginia. They have years of community partnerships, a lot of different resulting initiatives, including mobile clinics, revive trainings, et cetera. And this is just more to show that, this large data can help pinpoint something that's really going right that might be lost in previous data, and allow us to figure out that there's something happening that we can learn from. And the goal is in the future to do qualitative interviews, and Marshall will talk about some of our community engagement work already to figure out what we can learn. So next steps, largely we want to help identify priority areas in Virginia. So using this broader big data with local context, doing qualitative interviews and surveys and integrating them together. We still need to refine our toolkit. We want to expand the menu of evidence-based programs, and we'd love to learn from you all to know of anything that you think is missing. And then finally, we want to translate evidence into practice. Having the data isn't always enough to overcome the barriers and practicalities of implementing it. So figuring out which communities have implemented a Narcan vending machine and how did they do that? And where did they get their supplies? Looking at those really practical factors, and that will be the next step in the next iteration of the toolkit. And so now I at the very end, we'll take some comments and suggestions, but right now I'm going to turn it over to Marshall to talk about some of our community engagement work.
Let me see if I can share my screen here. How does that look? Looks good? Okay.
They're good.
So I want to give you an example of what this community engagement process looks like or can look like. An example that we recently finished working on a needs assessment and gap analysis for maternal substance use needs in Central Virginia. And so I'll walk you through a little bit of somewhat at a high level of what our process looked like and what some of the findings were from that. And then I'll share a little bit about the statewide survey that we're doing and provide a link to that if anybody's interested in taking it. So maternal substance use is a rising concern in Central Virginia. We have 7% of Virginia women of childbearing age entering into substance use treatment that are pregnant at the time of admission. And we also have 7 babies born per month that are experiencing neonatal abstinence syndrome. So this is a concern, and we were approached by the localities of Henrico, Hanover, and Chesterfield counties in the city of Richmond to say we would like to focus on this population. We want to understand better about what are the needs of this population, what are the gaps in services for them, and what are the types of things that we need to do in order to improve the substance use treatment for this particular population. A fourth component of this is anecdotally hearing from the Department of Social Services and Community Service Board that reporting of neonatal substance use exposure has been decreasing over the past several years. And so digging into this question of, we know that this is happening, we know we have lower rates of this, but we don't exactly understand why this is and what are the points of intervention. So we did a needs assessment and gap analysis. Worked with Henrico, Chesterfield, Hanover, and the city of Richmond to identify what are some of the key stakeholders that we need to be talking to in order to understand this. And we were guided overall by 3 questions. What are the major system level gaps available for this population? What are the barriers that they're facing in accessing services? And what are recommendations for improving the substance use treatment system? So we approached this and from multiple different perspectives or different angles. Jackie showed you a little bit of the claims analysis that we did that informed this. I'm going to focus on more of the community engaged portion of things, which included in-depth interviews and a community needs assessment survey. So the survey we had consists of 28 questions. We got 89 responses across the 4 localities from a wide spectrum of folks in various different positions within the treatment and services spectrum. And for our survey findings, this is just a kind of high level, just some of the highlights from it. Identified areas that need or greatly need improvement, and it boiled down to increase in housing-based or residential recovery services, safe childcare options, peer recovery services, and then a particular focus on better services for those incarcerated or reentering into the community. And then substance use training for social workers and case management. And that has to do with that hospital reporting component of things. And I'm not going to be able to talk through all of these. We're only going to talk through, I'm going to provide a little bit of an overview of what we heard from folks through the interviews on the housing, childcare, and the peer support services components of things. So for the interviews, we talked to 35 individuals across the spectrum of services and providers. in community service boards, VDH, health departments, in recovery housing and preventive services, the hospitals and jails and prisons. So we tried to get lots of different perspectives to understand these issues. And one of the overarching main problems that we heard, challenges across the board, no matter where you were, what type of person we were talking to, is housing challenges. So overall, recovery housing is unavailable or largely inaccessible to women with children. That this is simply just not available. What little services there are available are extremely limited, long wait periods, but by and large, most of the recovery. And so going back to Jackie showed the one chart of, we have a lot of recovery housing that is over the past several years, more recovery housing being available, but that's largely either for single adults or men. So nothing available for women with children. Of those services that do exist, some of the rapid rehousing program that do exist, there is no wraparound supports that come with those. And so that was identified as a lack of that. There's not any kind of comprehensive supports that is tailored to meet the needs of women with children. And then we also heard concern about a lack of standards and oversight for the housing programs that do exist. And so a concern that folks were not being plugged into the treatments, the types of treatments that maybe they preferred, and that there was potentially harsher, more punitive standards being applied to the residents that live there. So some of the recommendations that we offered as part of this is design recovery housing to meet the needs of women or children. So this means larger living spaces that can accommodate families, as opposed to co-living spaces where in a lot of housing programs where you have adults living multiple beds in the same room in these cohabitated spaces, not conducive to women with children that need a little bit more privacy, need a little bit more room. Also provide wraparound services as part of that. So that this population not only needs a place to lay their head, but they also need on-site childcare. There needs to be education and support for parents and for the children and the parents themselves to build up their families. Transportation services in order to help them get to jobs or to get to treatment. And then also on-site mental health services. So that's both crisis services, but also counseling. One of the issues with the lack of long-term housing options, emergency shelters are kind of the default or the default option for a lot of folks. One of the needs identified within the emergency shelters themselves is crisis support counseling available for folks that are in that setting. And then the recommendation to increase standards for housing quality and accountability, and including potentially creating a community-centered oversight board that can provide some of that guidance. Childcare challenges, and this goes along with the housing challenges as well, but in the sense of high cost of that childcare is unaffordable and inaccessible. It's a high cost, and it compromises people's ability to really engage in their recovery. Because if you can't afford childcare, then you can't make it to go to work. And if you don't have childcare, you're not able to engage in recovery, because you're not able to go to your counseling sessions or your treatment sessions, because a lot of those are not open to or able to accommodate a parent coming along with one or more children. And again, a lack in services that will accommodate those issues. For those childcare services that are available, even if they are that there are vouchers for them, or that they're somehow made to be more affordable, that there's limited flexibility in those in terms of being able to provide either after hours childcare for people that are working not a 9-to-5 job, that may be working more evening or nighttime hours or weekend hours as well. For some of the recommendations around that is potentially creating more on-site childcare in treatment facilities themselves. So when somebody comes to go to their treatment, to go to their peer support groups, to go to counseling, that they can have on-site childcare, that during that hour or 2 hours or whatever it is, that my child can be taken care of. Expand the availability of childcare options for those off hours to accommodate people's jobs that are happening at different times other than that 9 to 5, and also creating a resource list that allows people to identify what are safe, embedded childcare options in the community. Because one of the things we heard is parents being hesitant to send their newborn babies to be watched by people that they don't know or trust. And then the last area we'll talk about is heard a lot about peer support challenges. And this is peer support challenges. It wasn't so much as identified as a challenge. This is the value of peer support. And this is something that came through in the interviews, is how much using peers and integrating them across the board, across services, was such a value. And the main issues with this is simply not having the available funding or resources to do that, and not having enough peers that were either qualified or certified in order to be able to be plugged in. And so folks really emphasize that we need to integrate peers more. We need to support those peers more, and we need to do that in more settings. And so recommendations being, incorporate peers across the care continuum at every stage of treatment during pre-pregnancy, pregnancy, and postpartum care, so that we have that more familiar interaction in creating relationships of trust and respect with folks across their time. Embedding, one idea that came up was creating community-based citizen groups. It was called, the person referred to it as a citizen group, but of peer specialists that are embedded within high-need neighborhoods. And we often think about peer services being an adjunct to or embedded within particular providers or agencies, but to have them embedded within the community and being that as a bridge between service providers and social service agencies and the communities themselves. And then another area was within family and home visiting programs. So to help with that outreach, and this gets to some of the feelings of stigma or distrust that a lot of families have to anybody providing home visiting type services, that potentially that there's going to be reported to CPS and there's a risk of losing their child. And so in having peers available that can help bridge that gap. The other component to that, it was recommended that peers, especially peers with substance use experience themselves, are going to be better equipped and skilled and knowledgeable about identifying potential substance use issues among the families that they're working with. So if it's families that are being worked with by home visiting service, that there isn't necessarily a known substance use problem at the time, peers being available to identify those earlier and to provide prevention and intervention services at an earlier time. So some of this work, and I didn't report on it all here, but was informed by a community needs assessment survey we're doing. The work that we did with the 4 localities as part of this needs assessment was much more focused on the maternal health needs. But the survey is focused on, the statewide survey that we're conducting is focused on substance use, opioid use, treatment service needs more broadly across the board. And so we're it's 28 questions long. It takes about 25 minutes or so to complete, potentially less than that. I wanted to be a little bit more conservative in my estimates there. But it covers 4 areas of interest to hear about. And this is where we want to be able to understand what are the needs of the communities around the state, and to hear what are the suggestions of what they need more of, so that we can help put that into our toolkit, and so that we can have our toolkit responsive to the needs of the communities, to identify needs of the communities themselves. So identifying what types of services your organization provides and the challenges that it's facing. What are the opioid related resources that you already have, but then where are those gaps in services and barriers that you think are there? What additional resources or tools do you think are needed to improve that? And then a special focus on the unique needs of pregnant and postpartum women, because this is not a population and the challenges that they face that is unique to the areas that I've just been talking about, but it is certainly statewide. So I'll also provide, let me see if I can do this. Link it in the chat. I'll stop sharing now. But a link to the survey in the chat if anyone should be so kind as to want to take it. Thank you.
Fantastic. Well, thank you both for that presentation. And remarkably, we have no questions. So I don't know if everyone's just still kind of waking up or what, but I thought all of that was, really valuable information, obviously, but really pretty intriguing. So, I mean, I'll just take an opportunity to make a couple of observations and questions if you all have a couple of moments just to continue the conversation here. But obviously housing is a really important and widely acknowledged element of the continuum of care, right? And many times is under-resourced, right? And so you'd mentioned that at some point, perhaps from a policy perspective, probably due to funding, we moved away from a supportive housing model to a rapid rehousing model. Can you kind of explain what's the difference between supportive versus rapid rehousing?
The way it was explained to me by folks working in that space is rapid rehousing seeks to provide for people's basic, and so on principle, there's nothing wrong with this, right? So it provides for people's basic needs housing first and foremost and rapidly, and then they're able to then reach out and to engage in other substances, other services, and are able to engage in recovery better. So on principle, that's wonderful. The problem in that works for lots of people. The problem that was brought up is that works for people who already have some modicum of social support network available to them, or they're easily tap into it, and it doesn't work as well for those who don't have that. And so we're saying, so specifically mothers with children who need a lot of the other wraparound services, who need that child care, who need house management training or education to be able to run a household with children, to do that, that are going to have more transportation issues because you got lots of children coming along. It's even hard to participate in public transportation to get on a bus if you have 4 kids that you got to go along with you. It's all that wraparound support that this population specifically needs more of, and that it provides more of a foundation of stability for longer periods of time that will set people up in their recovery journey better.
Yeah, thank you. That makes perfect sense. And also peer supports, right? So another aspect that is frequently identified as a really valuable benefit at all the different touch points, right? And so yeah, it's a little discouraging to see that there's high rates of turnover there, obviously, right? And I get that because it's a lot of times it's limited grant funding, and it's relatively low pay, right? So if someone has an alternative, and it's frankly, it's kind of tough work, right? Too, it's tough work, day in, day out sort of stuff, right? I will say though, Virginia did pass legislation last year, and you may be familiar with this, that reduced some of those barriers to entry from an employment standpoint for peer support specialists. So hopefully that could help address some of the supply availability side of the equation, but certainly pay and a continuing sort of funding stream to support peer recovery is going to be an important element to the overall objective, right? Yeah.
And I mean, I think that's especially the value of peer supports is it's able to, the folks, the peer support providers are able to provide, they're able to build relationships up. The value is in it is the knowledge, it's the lived experience and the expertise that they gain, but it is the relationships that they're building with the communities that they're working. And you can't sustain those relationships if you have a lot of turnover, and you're going to have a lot of turnover if the peer support providers themselves are having to look for new jobs because they're under-resourced where they are.
Yes.
So need to undo that cycle.
Absolutely. All right. Well, okay, it looks like Tyler, you dropped. Yeah, no, appreciate that. And I was going to say too, so this is obviously being recorded. This is going to be out there. If anyone has any questions, feel free to reach out. Tyler obviously just shared that contact information, and you're always welcome to contact the OAA, and we will help and provide answers and resources to the best of our ability every single time. This is all we do, right? So with that, we're a little bit early, but that's okay. We appreciate it. Dr. Britz, Dr. Brooks, Dr. Moeller, Tyler, everyone out there, thank you for joining us. Really appreciate all of that. And yeah, again, please join us for our next webinar. I forget the date on that. I don't have it up in front of me, so I apologize, but we will have more of these Abatement Academy webinars in the future, and we hope you join us then. And with that, I wish you a good day. Take care, everyone.
Thank you.
Bye, thank you.